Very pleased to welcome you to the Nuffield Trust. You're Chief Executive Officer of Compass Health in New Zealand. Can you tell me a little bit about Compass and its origins?
Compass Health is a network of primarily general practice providers that started in the early 90s as a GP based organisation with 33 general practitioner members. So it was based in Wellington City in the lower part of the North Island. The very significant difference between the New Zealand sector and some of the other Western countries is that development, which was an independent practitioner association development and based on general practice only, has evolved over the last 15 plus years and been maintained in some shape or form through a range of health reforms in the New Zealand health sector. And it evolved from the bottom up. So these are GP owned or led organisations. They're largely not-for-profit entities, although our general practices are still for-profit small businesses. But the network entity is a not-for-profit organisation, led largely in the first place by a board of general practitioners. So the hearts and minds, if not the financial benefit, of general practitioners are fundamentally embedded in these organisations.
So what's the advantage for a GP in coming together in a network, in organised general practice? What have been the benefits?
Well, the origin of the organisations were, in our case, twofold really. One was a quality agenda, and general practice as small businesses had started a strong sort of peer review kind of process and within their practices, and that naturally clustered up into several practices coming together for that. But as corporatisation of the hospital sector and the commercial viability of hospitals became questioned in the early 90s in New Zealand, and they started to be restructured and different accountabilities started to be put around them at that stage and in that particular reform. Some general practitioners could see that general practice was not going to stay the same regardless. It wasn't an option to put their heads down and hope that this would all happen around them and their life would remain as they had always known it. But an individual practice on its own was going to have great difficulty in responding positively or defensively to that challenge. So some of our GP leaders said we need to start to come together on some of this. Second of all, and a bit differently from a government and a funder perspective, it was at the stage where there was a significant growing concern around the growing costs of referred services, in particular pharmaceuticals and laboratory spends. And so they could see some value in GP-led quality improvement around prescribing practice and referral patterns into a range of referred services. So the benefits for GPs almost immediately started to emerge, both from their own enriching their own clinical practice and providing feedback of information and comparative information that they'd never had access to before. So in the early days it was really about that sort of just general flow of information, collegial discussion, clinical governance and pathway work. But almost as soon as the organisations were there, we became vehicles for other parts of the health sector to implement new service designs. So as hospitals were keen to shed services into the community, or various funding organisations wanted to create some sort of change, we increasingly became used to do that work. But because our leadership was embedded absolutely in general practice, it was the GP leaders leading the change. And the employment of managers, and like myself, in the management structure, our job was to do what the GPs wanted done.
Now, New Zealand faces some of the similar challenges to us in terms of demographics and rising rates of chronic ill health and limits on resources. So what sort of future challenges are facing networks like yours, and how effectively do you think you're going to be able to work with the acute hospitals, which are still, as in many countries, absorbing quite a large share of the resources?
We have the same questions around how do we do more with less, how do we shift resources into the community when our hospitals are still facing significant acute demand. Some of the targets in our own business cases at the moment do have really aspirational goals around that, like 30% reduction of admissions for chronic disease patients, like similar sort of reductions to presentation to ED, and the sorts of service innovation that goes around trying to achieve that are things like we have now engaged a whole paramedic workforce attached to our ambulance services who are mobile out there to be providing some of the visiting kind of monitoring sorts of services in the community, so that they're not simply transporting people to hospital. For the paramedic to engage with primary care teams rather than simply be funded to take people to ED and then the assessments and things be undertaken. So we're trying to shift the flow of patients, absolutely to reduce the demand on the hospital sector, but it's not easy.
So you've had a few days here learning a little bit about the new policy of GP-led clinical commissioning, I think it's fair to call it. What are your observations about the likely success of that based on your experience of organised general practice in New Zealand?
Well, first of all, we would die for the same opportunity in terms of being able to put something in place to manage a total integrated budget. I would have a question around GP commissioning as it's currently proposed, both from two primary perspectives, I guess. One is the absolute split between the commissioning and the provision role. Our experience has been much more permissive than that, and we are both commissioners and providers, and we would see that would need to be the case going into the future. Having said that, our history and probably our concern around needing a funder-provider split is the lack of trust around if one provider group holds the budget and also then is a provider of services, then anyone else other than that provider will be concerned about that for sure. So if anyone has total power and control, both as a funder and a provider, that's a problem. Now that has been our recent experience in our district health boards. They were the funder and they were also the secondary care provider, and we have complete lack of trust really about their judgment and the fairness and the decision making that occurs within the district health board environment, because it seems to be incredibly balanced and unfair, and the conflict of interest is there. Now, I'm not surprised that the conflict of interest questions are being raised in the UK around GP commissioning. If GPs were able to be both commissioners and providers, then it's not surprising that everyone else then in the sector will raise questions about that. What's happening in New Zealand at the moment is a sort of a step forward from that, and a realisation that any one party holding that budget is probably never going to be an ultimate sustainable solution. And what we're being challenged to put in place right now is what we call an alliance solution. So we have both the primary and the secondary care people around the table making the decisions about how the whole budget will be used and how the commissioning will then follow. But there is the freedom for that group to be both a commissioner or the provider directly of the service. So we do have the ability to decide not to tender a service and to simply provide it ourselves at a network level. How we get away with that, I guess you might say, is it has to be absolutely transparent and evidence-based around why you've made that decision. So, you'd have to say if the policy is going to give the GPs the total budget to commission, that's a huge leap of trust and faith. To then say that they're not trustworthy to make the decision that they would be themselves the best provider of the service, or the next evolution of primary care and general practice shouldn't allow the model of care to change in general practice, if that's the best solution for the patient and for the whole of spectrum service provision. It seems nuts to say no, they can't do that. They have to tender it out to someone else. That seems to me to put an immediate barrier in the way of ideal model of care development. The best solution has to be a joint approach to that if you're going to get a whole of spectrum solution. So the recent suggestion that the GP commissioning group should have secondary care and nursing participation, we would support, in our experience in New Zealand of doing that, is very positive.